Dr. Oliver Dorigo is the director of the Division of Gynecologic Oncology at Stanford. He completed a clinical fellowship in gynecologic oncology at UCLA Cedars-Sinai Medical Center in Los Angeles, California. Dr. Dorigo was then appointed as the director of the Stanford Gynecologic Oncology Service. At Stanford, he is directing the clinical research group, which is conducting clinical trials for gynecologic cancers that mainly involve immunotherapy and PARP inhibition. In addition, Dr. Dorigo directs the Gynecologic Oncology Clinical Care Program at Stanford Women's Cancer Center. He has a well-established laboratory that is focused on studying the role of the immune system in ovarian cancer. Dr. Dorigo's scientific work is published in various scientific journals, including Nature, Cell Development, Journal of Virology, Proceedings of the National Academy of Sciences, Journal of Immunology, Cancer Research, Communications Biology, and Cancer Gene Therapy. Please welcome Dr. Oliver Dorigo.
Well, good afternoon. I'm Oliver Dorigo. I'm the director of the Stanford Division of Gynecologic Oncology. We do our work here at the Stanford Women's Cancer Center and the Stanford Cancer Institute. It's my great honor and pleasure to talk to you about the recent advances that we have made in the treatment of ovarian cancer. I happened to just do a surgery in the morning of one of my ovarian cancer patients. I'm now here in my research lab where we actually investigate new therapies for ovarian cancers. The landscape for ovarian cancer in 2021 looks as shown here on these estimated new cancer cases and deaths in females in the United States. In 2021, we expect about 21,410 women to be newly diagnosed with this disease. This is not the top 10 most common cancer in the United States anymore. However, on the right side is shown that 5% of all deaths in patients in the United States in the woman population occur from ovarian cancer, and so 13,700 patients succumb to the disease, a mortality that is certainly way too high. We have, however, made some progress. And shown here is that the annual incidence, which is the number of newly diagnosed ovarian cancer patients on the left side, is decreasing year by year. Between 2013 and 2017, the incidence of ovarian cancer declined annually by about 1.8%. And we do attribute this to a number of different factors, but particularly to the idea that hormonal contraceptives do decrease the risk of ovarian cancer development. The death rate is likewise declining, and I think that's a really piece of information that is very positive, annually by 2.3%, and that's, I think, a testimony to the great progress that we have made in this disease. Now, ovarian cancer is still affecting women that are older than 45 years of age. In the general population, the median age when patients are diagnosed is about 63 years. And you see the age distribution shown here. Death due to ovarian cancer occurs in average at the age of 70. The diagnosis of ovarian cancer is early in those patients that have genetic mutations, particularly BRCA1 and 2 mutations, while BRCA1 carriers in average develop the disease around the age of 54. For BRCA2 carriers, that's a little later with 59 years. So the diseases, when there's a genetic predisposition, occur a little bit earlier in life. The ovarian cancers, as we know it nowadays, often originate in the fallopian tubes. I show you here a picture of what this might look like, where within the fallopian tube, the cancer developed that secondarily spreads to the ovary. And that's particularly so in those patients that have genetic predispositions for example, BRCA1 and BRCA2 mutations. We've recognized this phenomena when we started to prophylactically take out fallopian tubes and ovaries and realized that in those patients, although they had no evidence for disease on ultrasound, pelvic exam, no symptoms, we found in about 5% of patients that the fallopian tubes had early cancer cells in them. The ovarian cancers, as we know them, are subgrouped in many different cancers. And I might say that the ovary is the most creative organ in the human body because it can make a lot of different tumors. I show you here the most common subgroup of ovarian cancer, which is called the epithelial ovarian cancer. The epithelial cancers originate mostly from the surface of the ovary, while other cancers originate from the inside of the ovary. And even among the epithelial subgroups, we do differentiate between different histologies, and that's what the pathologist tells us under the microscope. The most frequently found histology is the high-grade serous carcinoma, shown all the way on the left side. But we also see cancers that we call low-grade serous carcinoma, mucinous, clear cell, or endometrioid epithelial ovarian cancer. We have learned over the last years that each one of these cancers is characterized by a certain mutation profile. And listed here are the typical mutations that we see in the respective subtypes. On the left side, in high-grade serous ovarian cancers, the P53 mutation is present almost in all of them, while BRCA1 and BRCA2 mutations are present in about 25% of these cancers. Low-grade serous carcinomas do not frequently have BRCA mutations or P53 mutations. They're characterized by mutations in BRAF or KRAS. Similarly, mucinous, clear cell, and endometrioid carcinomas have very characteristic mutations that are important for us to identify for the design of more targeted therapies that are directed towards these mutations. We, as you know well, do a lot of mutation testing in ovarian cancer patients. Every ovarian cancer patient nowadays is tested for inherent defects or mutations in their DNA. Shown here are the most common gene that we are looking for. They do include BRCA1 and BRCA2, but also genes listed under the Fanconi anemia pathway like RAD51C or RAD51D. And then among those Lynch syndrome and mismatch repair pathway genes, we're interested in mutations in MLH1, MSH2, MSH6, and PMS2. So a panel of genes that for us is important to analyze if we were to identify mutations that patients are born with and mutations that greatly can increase the risk of developing ovarian cancer in the patient's lifetime. There are a number of different assays that are available nowadays to test both for mutations in the germline or the DNA of patients and in the DNA of the tumor tissue. I've listed here a few of these tests that you might be familiar with. At times we use blood or mouth cells. In a number of cases when tumor tissue is required, we send those paraffin blocks from patients' tissue that are stored in the pathology departments for very extensive sequencing by different platforms. We have at Stanford our own test, which is named STAMP, that can look for mutations that are important for us to identify for the right treatment decisions. When we identify patients that have a high risk of developing ovarian cancer, for example, BRCA1 and BRCA2 mutation, we can talk to our patients about the prophylactic removal of the fallopian tubes and the ovaries. I'll show you here on the left side how this is usually done. This is a laparoscopic procedure, which is minimally invasive. A camera is inserted into the patient's abdomen, usually through the belly button. Additional instruments are then used to dissect the fallopian tubes and ovaries away from the uterus. These organs are then removed, a procedure that greatly reduces the risk of the development of ovarian cancer. In the right upper corner is what we see in laparoscopy. This is what a uterus, fallopian tube, and ovaries look like in the pelvis. I put Angelina Jolie's picture on this slide because she became some of the poster child of prophylactic surgery, since she likewise has a BRCA mutation and elected to undergo both a prophylactic mastectomy to prevent breast cancer and removal of the fallopian tubes and ovaries to prevent the development of ovarian cancer. We have tried for many decades to find ways to screen for ovarian cancer. We use transvaginal ultrasound, the tumor marker CN25, pelvic exams, symptom screening, but none of these technologies, even combined, have shown to be effective to discover ovarian cancer early on. I show you here a transvaginal ultrasound, which is still the best way to image the ovaries. On the right side are shown examples of ovaries that have suspicious areas that would certainly consider a surgery, removal of the ovary, and then acting appropriately based on the histology. But these ultrasound pictures are not very predictive of the final diagnosis. Our guidelines, and this is your US Preventive Service Task Force, does not recommend screening for ovarian cancer. As a matter of fact, screening for ovarian cancer with regular ultrasound, CN25 tumor markers, other tests like the OVA1 test, and pelvic exams can lead to unnecessary surgery, and the resulting complications from the surgery can induce harm from screening. We do not recommend, therefore, screening of patients for ovarian cancer. We have done these studies over many years, and hundreds of thousands of women have entered in these studies. But again, we're still lacking a meaningful screening strategy for ovarian cancer. I want to show you here how we treat ovarian cancer. I look at this in two different phases. The first phase is the initial treatment. It's a combination of surgery and chemotherapy. In about 50% of patients with advanced disease, surgery is done up front, followed by 6 cycles of chemotherapy with carboplatin and Taxol, and sometimes with the addition of bevacizumab or Avastin. In the other 50% of patients in the United States, the chemotherapy precedes the surgery. We usually do 3 cycles of chemotherapy, then a CT scan. If the patient responds to the treatment, perform a surgery which we call interval debulking surgery. Here at Stanford and in some other selected institution, we also, at the time of that surgery, use intraperitoneal heated chemotherapy called HIPAC, which has shown in one major clinical trial that it can increase the overall survival of patients. I performed a surgery like this morning, and I certainly hope that this patient will do well. We have also made progress in the maintenance treatment, which is part of the initial treatment. The maintenance treatment starts when surgery and chemotherapy is completed, and I will get into this in my next few slides, involves either the administration of oral drugs called PARP inhibitors, or the continuation of bevacizumab treatment, or a combination of both. Now, unfortunately, particularly in advanced disease, the majority of patients still recurs with ovarian cancer at some point in time. And these patients then are treated for recurrent disease. The recurrent disease is treated with different chemotherapies. We try to continue a carboplatin or platinum-based regimen as long as the ovarian cancer stays sensitive to the platinum-based chemotherapy. We do at times use surgery to remove recurrent disease. We have used radiation, and more recently have introduced targeted therapies and immunotherapy for the treatment of patients with recurrent disease. Now, as stated, the treatment landscape for ovarian cancer has changed rather dramatically and rapidly over the last 6 years. We in 2078 had the first drug approved for ovarian cancer was cisplatin, which was the drug of choice for many of our patients. We then added a number of different chemotherapeutic agents as shown here, including carboplatin, paclitaxel, topotecan, gemcitabine, liposomal doxorubicin. And this was an era of chemotherapy that used drugs that were not specific to the patient's tumor. In the last decade, we started to think more carefully about who to treat with what specific drugs. We developed these so-called PARP inhibitors that are particularly effective in those patients whose tumors have defects in DNA repair. And I will tell you in a moment what that means biologically. But as you can see on the right side of the interrupted red line, we have now drugs approved, including bevacizumab, olaparib, niraparib, and rucaparib PARP inhibitors that have made a very meaningful difference for our patients. Now, I show you here how we have capitalized and taken advantage of the inherent deficiency of DNA repair mechanisms in cancer cells. When you follow this chart here on the left side, DNA in the cancer cell breaks. Chemotherapy works by cutting pieces into the DNA, and when the DNA is too broken, the cancer cell cannot repair it anymore and dies. Now, a normal cell is actually very effective in DNA repair, and therefore, chemotherapy usually doesn't harm too many of the normal cells. Now, as we identify those mechanisms that allow the cell to repair its DNA, we came upon enzymes and other proteins that are actually very important in this process. I show you here what PARP stands for. It's poly-ADP ribose polymerase, which is an enzyme that is involved in repair of DNA. The drugs that I mentioned, olaparib, niraparib, rucaparib, are all blocking this enzyme PARP and inhibit or block the cells from repairing its own DNA. And when there's enough DNA damage in a cell and the cell cannot repair its DNA, it will die. Now, PARP inhibition, as I said before, is particularly effective in those patients that already have an inherent defect of DNA repair, and that's particularly in those patients that have BRCA1 and BRCA2 mutations. These three PARP inhibitors have now been approved by the FDA, both in the first-line and second-line maintenance. Now, what does maintenance mean? We talked about the completion of the initial phase of treatment for ovarian cancer patients, which is followed by the maintenance. As shown here, patients do not only experience one recurrence, but many recurrences following once this cancer has recurred once. The intervals between the recurrences tend to get shorter and shorter. The goal of maintenance therapy is to extend and prolong the intervals between the different recurrences. We've tried for decades again to achieve this goal, but it wasn't until we found PARP inhibitors, as mentioned, that we were able to demonstrate a very meaningful difference for our patients. Shown here is a slide from one of the most impressive trials that we have all ever seen in ovarian cancer patients. This is a population of advanced stage ovarian cancer patients that all have a BRCA mutation. These patients were treated with chemotherapy and surgery and then placed on olaparib, the PARP inhibitor. Shown in the red line in the upper part of this graph are those patients that took the olaparib, and on the lower curve are those patients that were treated with placebo. The median progression-free survival, which is the time to when the cancer recurs or gets worse, was 56 months, so almost 5 years in those patients that took the olaparib, versus about 14 months only in those patients on placebo. This is a 42 months difference between those patients on the drug versus patients on placebo, a difference that is nothing else but stunning in our world of oncology. We also have combined olaparib with bevacizumab. This is, I think, a very novel approach where patients with tumors that are not BRCA mutated still benefit. Those tumors usually have defects in what we call homologous recombination. Your physicians usually send tumor tissues, if you're not BRCA mutated, to one of the testing platforms, and we then learn from those data whether tumors are deficient in homologous recombination, which we call HRD positive, or proficient or able to undergo homologous recombination or able to repair their own DNA. On the right side is shown the outcome for those patients whose tumors are very able to repair DNA. And for those patients, the difference between treatment with a PARP inhibitor and no treatment is rather minor. The other drugs that have shown that we can make this work outside of olaparib, this is Neuroparaben Maintenance in patients with newly diagnosed advanced stage ovarian cancer. Those patients all have a deficiency in their tumors of DNA repair called homologous recombination. As you see here in the blue line, those patients on the drug or Neuroparaben had a progression-free survival of 22 months versus only 10.4 months in those patients that took the placebo. Again, a very meaningful and statistically significant difference between those groups. Again, this works well in those patients that have BRCA mutations in their tumor. It doesn't work as well in those patients, as shown on the right side, when tumors are able to repair the DNA. And it's important for you to talk to your physicians about the molecular makeup of your particular ovarian cancer if you were to choose a treatment with a PARP inhibitor. So I show you here in summary how we think about the first-line treatment with PARP inhibition as maintenance therapy in ovarian cancer. So those patients that are newly diagnosed with advanced ovarian cancers undergo treatment if they have a BRCA mutation. They will be treated as maintenance therapy either with a PARP inhibitor alone or a combination of a PARP inhibitor with bevacizumab. If you have no mutation in the germline of your patient or your BRCA wild type, then we test the tumor. If the tumor turns out to have a defect in DNA repair, then we talk to our patients about PARP inhibition. And it's a little bit more difficult to discuss those situations where the tumor is very able to repair its DNA, so a tumor that is homologous recombination proficient. Those patients do not have the same efficacy of PARP inhibition. PARP inhibition doesn't only work in those patients after first-line treatment. It also works, and it was actually initially studied this way, in those patients that have recurrent platinum-sensitive ovarian cancer and BRCA mutations. Shown here is one of the first trials that showed the evidence. It's called the NOVA trial. In this trial, patients that recurred with ovarian cancer were treated initially with a platinum-based chemotherapy regimen, for example, carboplatin and Taxol. If they responded, we called them platinum sensitive. The group of patients that was treated with niraparib did significantly better compared to those patients on placebo. Shown on the right upper quadrant is the progression-free survival, with 21 months in the niraparib group and only 5.5 months in the placebo group. And this treatment was adopted a few years ago. We talked to all of our patients about PARP inhibition, regardless of their molecular status in the tumor, and that's shown here. Even in those patients that have tumors that do not have a deficiency in DNA repair, niraparib still has a meaningful benefit, as shown on this slide. But again, the benefit is still the greatest when patients have tumors that are either BRCA mutated or have other deficiency outside of BRCA in DNA repair mechanisms. I show here another drug, which is called Recurrence, that shows some very similar outcome. Again, those are patients with recurrent platinum-sensitive ovarian cancer. They're either deficient in DNA repair or proficient. And those tumors that are deficient, those patients have a meaningful benefit from the PARP inhibitor, while patients whose tumors do not have DNA repair defects do not seem to benefit as much from the PARP inhibitor. It's important for us to identify these type of defects because that allows us to inform the patients about the greatest benefits of PARP inhibition. We also have survival data. I so far presented progression-free survival, which is the time to when the tumor recurs or gets worse, but overall survival data is still not abundant. But I show you here one trial, which is a trial in patients that have recurrent platinum-sensitive ovarian cancer. They all have BACC mutations. They're placed on olaparib after the completion of the chemotherapy. Those patients on olaparib had an increase in the overall survival of about 13 months at least when compared to the placebo. So a very meaningful overall survival benefit. And that, by all means, in this patient population is a huge benefit. We have to recognize, though, that PARP inhibition can also be used in those patients that have mutations in their tumors without a maintenance strategy. Here are patients in a trial that were treated with niraparib. In those patients whose tumors are BACC mutated, the overall response rates to a single agent oral drug, this is not chemotherapy, this is an oral PARP inhibitor, is about 39%. It's less so in those patients whose tumors are not deficient in homologous recombination, where the response rates drop down to about 15 to 10%. And this treatment is not as effective in those patients whose tumors are considered to be platinum resistant. But we talk to our patients about this option as a non-chemotherapy treatment for recurrent ovarian cancer. We've also combined these PARP inhibitors by now with other drugs that we do now work for ovarian cancer. Shown here is a trial that combines niraparib with bevacizumab in patients with platinum-sensitive recurrent ovarian cancer. And up in the red lines on both sides, regardless of whether the tumor is deficient or proficient in DNA repair, both of these cohorts have a meaningful increased benefit from the combination of niraparib, the PARP inhibitor, with bevacizumab. So you, as a patient, have the option with platinum-sensitive disease to be treated with a regimen that is not chemotherapy. Those are IV infusions every 3 weeks with bevacizumab or Avastin, and oral intake once a day of niraparib. And it's an example on how we're trying to introduce non-chemotherapy treatment for our patients with ovarian cancer, which by all means can have an important impact on the quality of life of patients. Chemotherapy, as we all know, has a number of side effects that can significantly impact on well-being, quality of life. With those regimens that are not chemotherapy, as shown here, the quality of life is, in general, far better. We're working on other regimens. This is one example, but it's a promising step forward. Now, as expected, PARP inhibitors and other drugs do not come without any side effects. In general, these PARP inhibitors are fairly well tolerated. There are two side effects that we're very concerned about, and they both have to do with the bone marrow. Some patients develop what we call myelodysplastic syndrome or acute myeloid leukemia. Shown here are data from the SOLO2 and NOVA trial that indicate that up to 8% on patients with long-term treatment of olaparib or niraparib can develop these type of bone marrow toxicities. And those bone marrow toxicity can be fatal. So we have to be careful about following patients on PARP inhibitors. We have to inform our patients about these side effects. We don't have enough long-term follow-up data to be very conclusive about these numbers, but it's certainly something that we need to be aware of, and again, inform our patients in conversations regarding the decisions of PARP inhibition. So I want to, in the second part of my talk to you about immunotherapy, because I know it's a topic that a lot of you are interested in. Immunotherapy has made a very important and significant difference in patients with many different cancers, including melanoma, lung cancer, renal cancer, and many other diseases. Immunotherapy includes a number of different approaches that I've shown here. On the left side is shown a vaccine approach where the immune system presents to the tumor, the immune system gets stimulated by a tumor-associated antigen or by certain proteins that stimulate T cells within the body's within the patient's body. These vaccines, and I show an example of this, are starting to show some efficacy in ovarian cancer patients, and this efficacy is actually very promising. You know about CAR T cell trials, or trials that use cells from the immune system that are either extracted from the tumor tissue or from peripheral blood. We can modify these cells in our laboratory and direct them against the tumor. Or we can use what's called immune checkpoint blockade against molecules called PD-1, PD-L1, or others as listed here. Those are pembrolizumab, nivolumab, as some examples of immune checkpoint blockade. Now, in ovarian cancer, unfortunately, immunotherapy hasn't worked as well as in other cancers. Immune checkpoint inhibition is a stimulation of T cells within the immune environment. The immune environment in ovarian cancer is extremely immunosuppressive. And one of the main mechanisms the tumor uses to protect itself is the expression of PD-L1, as shown in the lower right here. PD-L1 binds to a molecule called PD-1, which is expressed on T cells, and this interaction blocks the T cells from killing the cancer cell. We can interrupt this interaction by antibodies against PD-1. Pembrolizumab, for example, is such antibody, or against PD-L1. And once we interrupt this interaction, the T cell remains active in the tumor microenvironment. We've done a number of different trials in ovarian cancer. I show you here one of the largest trials that included 376 patients with recurrent ovarian cancer. It was called the Keynote 100 study. And the tumor activity was about 10% in the overall cohort. It was higher in those patients that had PD-L1 expression in their tumors with over 10% of all cells. But it wasn't up to those percentages that we used to see in patients with other cancers. We still use some of this immunotherapy in our patients, but we are selective about those patients and trying to treat those that have high PD-L1 expression in their tumor tissue. Showing another trial where we combine two different immune checkpoints called nivolumab and ipilimumab for recurrent or persistent ovarian cancers. The response rates were really much higher than we have seen it before, with about a third of patients responding, but the duration of the response was rather disappointing. So even using two immune checkpoint inhibitors did not have the efficacy in ovarian cancer that we would have hoped for. Just like PARP inhibition, we have started to combine immunotherapy with other drugs. And I show you here a study that combines the PARP inhibitor niraparib with pembrolizumab in patients with recurrent platinum-resistant ovarian cancer. So it's the combination of immunotherapy with PARP inhibition, and treated in this trial with 60 patients. 3 had a complete response, which in the platinum-resistant ovarian cancer population is rather impressive. And we had 8 additional responses, leading to an overall response rate of about 18% in those patients. If you add to that the number of patients that had stable disease, so the disease did not progress, the disease control rate was 65%. It's a regimen that I personally use in some of my patients, and I've seen some really good responses. This response is not dependent on the presence of mutations in the tumor. So whether patients have BACC mutations, whether the tumors are deficient or proficient in DNA repair, does not seem to affect the efficacy of this combination therapy. We have combined nivolumab, which is, again, immunotherapy with bevacizumab, the drug that targets tumor vessels. And in a trial, as shown here, with 20 patients with platinum-sensitive and 18 patients with platinum-resistant disease, we see some very reasonable response rates, with 40% in those platinum-sensitive patients and about 16.70% in platinum-resistant patients. Again, this efficacy does not seem to be dependent on BACC mutations, nor does it seem to be dependent on the expression of PD-L1. What this demonstrates is, first, that we have therapies, again, that combine immunotherapy with an established drug, Avastin, with a very meaningful response rates. It's not chemotherapy, and therefore the side effect profile is in favor for the patient. And we have 2 drugs that help each other to work in a way that we don't completely understand, but it's independent of the molecular features that we usually apply to the selection of these agents. Now, checkpoint inhibition, any immunotherapy, can cause a tremendous amount of inflammatory toxicities. We are very lucky at Stanford because we have Dr. Tamika Katsumoto from the Division of Immunology and Rheumatology, who really directs us in managing those immune-related toxicities. These side effects in immunotherapy can involve any organ system. As shown on the right side, we see most commonly effects on the thyroid. We have observed effects on the gastrointestinal tract. Patients can develop pneumonitis. It's an inflammation of the lungs that can be very difficult to treat. If any of these symptoms occur, then we usually use immunosuppressive therapy, including steroids, and again, work together with Dr. Katsumoto. But immunotherapy is not without side effects, and we have to be very careful in selecting the right patients for this approach. Now, as I mentioned, we have made progress, and we continue to study new therapies for this disease. I am personally, and I have been for a long time, involved in the development of vaccines for ovarian cancer patients. In principle, we are now able to take tumor cells from the patients. We can isolate those peptides that we think stimulate the immune system the best. We can present these peptides by re-injecting them into the patients and then hopefully get an anti-tumor response that is systemic and discovers and sees all the tumors inside the patient's body and then kills those tumor cells. I show you here one approach that we have really taken the lead on here at Stanford. This is a multi-institutional study that I've been involved in for a few years now, and it's shown some really very significant efficacy in some patients. In this case, we use a protein that's made by ovarian cancers very frequently. It's called survivin. We have 5 different small proteins that are derived from this big survivin protein that we inject into patients' skin. And that vaccine stimulates a very potent T-cell response against the tumor. In our current trial, we do combine this vaccine with cyclophosphamide at very low doses. It's originally a chemotherapy drug, but at this dose level, which is, again, very low, helps the immune system to fight the cancer. We've seen, as I said, some really promising anti-tumor responses. Here's some initial data from some patients that have clinical responses that last for 2 years and more. And it's particularly important to note that a number of our patients on this trial had platinum-resistant disease, which in general has response rates of only 10%. We are developing this type of vaccine further. I'm presenting new data next week at the Society of Immunotherapy in Washington, and then further data in Europe at the European Society of Medical Oncology. So keep your eyes to the ground. I think we have a very promising approach here that we hope to get to our patients in the next clinical trial. Cell therapies. Again, I think a very promising and exciting new era or area of oncology treatment. In general, cell therapies involve the isolation of cells either from the tumor or we extract them from peripheral blood. We can take those cells to the laboratory, we can modify them genetically, we can expand them to make literally billions of them. And when we have those cells that we think really recognize the tumor and kill the tumor, we reinfuse those cells into the patients. The genetic modifications do involve the expression of a T-cell receptor, which can be very specific for a certain tumor antigen on the tumor cells, and it's our task to identify the right antigens. We also have technology that involves the so-called chimeric antigen receptors, or CAR. Those are a little different, but in principle, likewise, do recognize very specific tumor antigens. And this technology really allows us to generate very specific T cells that target very specific antigens or proteins on the tumor. And not only does it increase the efficacy on the tumor cells, but also makes this therapy more specific to the tumor cells and hopefully decrease the side effects on normal tissues that our current, particularly chemotherapies, have. I show you one trial that I'm guiding here at Stanford that we have developed over the last 5 years as a clinical trial. This was initially invented here by Stanford researchers about 20 years ago. It took us a long time to get this trial up and running since it's a very complex type of treatment. But in principle, we take blood from patients. We isolate certain cell populations from this blood. We expand them in our laboratory and generate a population of cells that's called cytokine-induced killer cells. When we have enough of these cells are infected with a virus. It's called a vaccinia virus. That vaccinia virus is genetically modified to not cause harm for the patient. These virus-infected cells are then infused intravenously into the patient. They find by a specific mechanism the tumor cells. They release a virus. The virus replicates inside the cells, and by now we all know what replication of a virus means. But once the virus replicates in the cell simply dies. Now, the virus then infects a neighboring cancer cell and does the same thing. It replicates and kills the cells because it uses the cell's energy and machinery so that the cells can survive. When it infects a normal cell, it cannot replicate since the normal cell doesn't supply the virus with enough energy to replicate, and therefore the normal cell is spared from the effect of the virus. We call this an oncolytic vaccinia virus. We have treated so far 3 patients with this approach and 2 ovarian cancer patients of our group. I cannot tell you much about the results yet. It's too early, but it's certainly a very exciting new approach for patients with this disease. I show you here again the tumor selectivity, where the cancer cells is killed by the virus. The normal cells is spared simply because it doesn't supply the right machinery for the virus to replicate. I'd be happy to share more information about this particular trial outside of this meeting. So I'm going to spend some time on answering your questions, and therefore want to conclude with my summary slide. I hope that I've shown you that PARP inhibition, both in the maintenance setting and the treatment setting, makes a very meaningful difference for patients. And that effect of PARP inhibition is particularly pronounced in those patients that have BACC mutations, either in the tumor or in their own DNA. We have seen so far very disappointing efficacies of immune checkpoint blockade, the pembrolizumabs, the avelumabs, very modest clinical activity in ovarian cancer, but we're working on this. And I think that with combining immune checkpoint with standard chemotherapy or anti-androgenic agents like bevacizumab or PARP inhibitors, we might actually increase the anti-tumor efficacy. I'm personally very excited about the new therapies, including cell therapies and cell vaccines, because they allow us to customize a patient's therapy and therefore mitigate, prevent side effects, and make the therapy more effective. So I want to thank you for your attention. We do our work here at the Stanford Women's Cancer Center and the Stanford Cancer Institute, and I hope that Victoria left a few minutes for questions, and I'm happy to answer those. Thank you.
All right. Thank you, Dr. Dorigo, very much. You covered a lot of very valuable information. It's really exciting to see the advances that we're making in those treatments, particularly with the immunotherapies as well as those PARP inhibitors, as well as that recent clinical trial that you were that was recently published. We do have a number of questions that came in. We're going to do our best to get to as many of those as possible today. Unfortunately, we probably won't get to them all. We had a number of them come in. So I'm going to go ahead and start with some of the earlier ones that came in. One of our clients asked, are you recommending to not do CA-125 testing for BRCA positive patients? And I was wondering if you can just go ahead and touch on that, please, Dr. Dorigo.
Yeah, it's a great question. There's some debate about those patients that are at high risk for developing ovarian cancer. BRCA mutation carriers have up to 45% lifetime risk of developing ovarian cancer, and BRCA2, it's in low 20s, but it's still very high. We haven't proven that CA-125 truly is a screening marker for these patients. In my practice, actually, I do follow patients with BRCA mutations that are not quite yet at the age where we should remove the ovaries, or that simply want to delay the removal of the ovaries and fallopian tubes. I follow those patients with ultrasounds every 6 months and CA-125, but I tell my patients that this is not a proven preventive or strategy.
Great. Thank you so much. Another question came in. Our client was saying that they thought that the intraperitoneal therapy does not kill tumor cells or kill the tumor due to the envelope preventing chemo from getting into the tumor. And thus they thought that the IV therapy was better for when it came to the vasculature of the tumor. I was wondering if you could just touch on this a little bit.
Yeah, no, that's a great question. And there's still a lot that we have to learn about HIPEC, the heated intraperitoneal chemotherapy. Let me just clarify, we don't use it alone. We always use IV chemotherapy, 3 cycles, then do HIPEC at the time of surgery. At the time of surgery, we remove the entire tumor. But we think that the opportunity to treat the tumor right on site with very little tumor disease left after tumor debulking has benefit. We then, after the HIPEC procedure, continue with chemotherapy intravenously, recognizing you're absolutely right that most of the chemotherapy gets to the tumor by the vascular system.
Okay. Yes, we have a very sharp clientele. They ask great questions.
I know, it's great. Thank you.
Yeah, and with that said, just a little bit of clarification. So is the HIPEC treatment only done for, is it done for internal or interval debulking or just initial debulking? If you could just clarify on that, that would be wonderful.
Yeah, another great question. I'm glad there's so much interest because I truly like HIPEC. So as I mentioned, we have one trial out of the Netherlands that showed conclusively that interval debulking in HIPEC, if successful, increases overall survival by about 12 months. The same group in the Netherlands just finished a trial where they looked at the effect of HIPEC at the time of upfront surgery. So those patients with advanced disease that were completely cytoreduced or debulked received HIPEC and then followed by 6 cycles of chemotherapy. I don't have data of this trial yet, but we're in touch with this group. There's no other trial that really has shown that this truly benefits patients. We at Stanford like to really stay close to evidence-based medicine, and we have not expanded HIPEC into other indications than the indication that was proven to be of benefit for patients on the clinical trial. Victoria, I cannot hear you.
Oh, there we go. Sorry about that. That was, we have a number of other really great questions. So a few clients asked us a little bit about the PARP inhibitors. So one question is, what is the ideal time or start time once a person has completed chemo treatment to begin the PARP inhibitor? And how long is olaparib typically used for?
Great question. In first-line maintenance, we usually allow about 3 months before you start the PARP inhibitor simply because it was studied this way. In general, you want to wait for the toxicity of the prior chemotherapy to have improved, meaning if there are low platelets, if the hemoglobin is very low, you have to wait before you start the PARP inhibitor, simply because PARP inhibitor can decrease the hemoglobin, can decrease platelets, and you don't want to deal with these toxicities. So, I think in the first-line maintenance, up to 3 months is fine. When it comes to recurrent disease, the trials usually at about 8 weeks, and that's where we like to be. I think there's some flexibility here. We haven't really proven far out, let's say 6 months after completion of chemotherapy, whether PARP inhibition still is efficacious. So I would stay within this 8 to 12 week window. How long should olaparib be taken? Well, in the first line setting, we recommend 2 years. A small percentage of patients continues to take this, but we don't really know whether there is continuous benefit or additional benefit if you continue beyond 2 years. In the recurrent setting, you take it as long as you tolerate it and as long as it works. Now, I have now patients out there about 7 years on a PARP inhibitor, and we still don't know what to do at this point in time. We have never seen patients that didn't recur within that time frame. So it's still a lot of unanswered questions with PARP inhibition. I talk to my patients about the long-term side effects and make decisions together with them. But those are the current guidelines.
What a great problem to have now, right? That you're getting so far out and not seeing progression that you're like, what do we do now? It's like that Nike commercial. I've never ran that far.
Yeah, that's right.
So that's actually a great problem to be having.
Yeah.
As we know that toxicities can definitely impact whether or not an individual can continue on with the therapy. So in the event that an individual really can't go on for those 2 years and they have to stop prematurely, or maybe at the 1 year mark, what type of results are we seeing? Did they happen to do that analysis or see that within the patient population?
Yeah, no, this is a very smart question too. And I don't have a really good answer to that either, but how long do you need to be on PARP in order to get the maximum benefit? It's hard to know because there are too few patients that we have followed. The clinical trials don't give you that answer. I think, again, if you can make it to the 2-year time point without toxicity in the first line setting, you get the maximum benefit as far as we know. Whether 6 months or a year give you similar benefits, nobody really knows.
Yeah, and I guess we expect everyone to know all the answers. I apologize. My dog wanted to go ahead and ask a question there too. So sorry about that. I have
Yeah.
another question in here regarding those last slides. One of our clients wanted to know about vaccines being used to treat low-grade serous carcinoma and whether or not you've been able to use that.
Yeah, so it's another really great question. So the low-grade serous carcinomas are another challenge. And I think they're misnomer because they're low grades, but they're really hard to treat. They grow very slowly and are not very responsive to chemotherapy. I would love to see the low-grade carcinomas being included in the vaccine studies. We are not quite there yet. In general, they are a very different biological phenotype or genotype compared to high-grade serous carcinomas. But even the low-grade serous carcinomas, they do present antigens that we can use to design vaccines or T-cell therapies. So I see a great opportunity here. We are just not there yet. I think there are other treatments that are very promising. Whoever asked this question, I look into the RAMP 201 trial, RAMP 201. It's the combination of an FAK inhibitor and a RAS inhibitor. I think this is a regimen that has shown very promising efficacy. Again, RAMP 201 trial, it's open in different institutions. I'm trying to get it open here. It's not an immunotherapy. It's a targeted therapy against mutations in this tumor that is low-grade serous carcinoma.
Yes, and our clients, again, they are great with their questions. They're a smart bunch, and they're always thinking and keeping us on our toes. So I'm going to have just two more real quick questions here before we wrap things up, because we're wrapping up on time. One of our clients, I feel like we could talk about this, forever. And, this is really kind of a more complicated question. But one of the first ones that came in was someone asking, if someone is ovarian cancer free for 5 years, what's really the chance of a reoccurrence? And obviously, as you were showing, all of this can really be varying depending on your types of medications, the history of the disease. But do you have any comments that you want to make on that?
Well, first of all, congratulations. That is terrific. I'm so happy for whoever asked the question because you have a very good chance of being cured with this. So, we're talking about single-digit recurrence rates after 5 years, right? Because if you draw the curves after 10 years, and we don't have a lot of 10-year data, being disease-free at 5 years really predicts an absolute great outcome over the next 5 years and 10 years to come.
That's very encouraging. And so I'm glad that we were actually able to answer that question to that degree. And one final question here that came in at the end. I think there wasn't a lot of detail with it. They just said if you had any questions about Avastin or bevacizumab, but I'm not really sure exactly what our client was meaning in that regard and to what context. It sounds like, you're able to use that with both the PARP inhibitor as well as the PD-L1 inhibitor. So if there's any little last couple things, I know that that's a drug that used to be more widely used across multiple cancers, but now primarily used in only a handful. Do you have any final thoughts or comments on that?
Yeah, I want to say in general, bevacizumab Avastin is a great benefit for our patients, and we continue to discover even more benefits of bevacizumab. As I show you, combining this with immunotherapy, with PARP inhibition, has additive or synergistic effects. We don't know exactly how this works, but we see it in clinical trials. So, I personally love this drug. I have no interest in Genentech or mix it, but this drug really, if used correctly in combination with chemotherapy as maintenance therapy, now in combination with olaparib, first-line maintenance approved, it makes a very significant difference. I'm again selecting my patients very carefully for bevacizumab, but I use it, and my group does it very frequently in ovarian cancer patients. And I would predict that we're probably going to see even more of this. The question regarding vaccines, when you use bevacizumab in combination with a vaccine, you actually get some enhanced efficacy of the vaccine. Bevacizumab makes T cells invade or infiltrate the tumor better. So, Again, a mechanism that we just recently identified, and a mechanism that can be very helpful in the design of vaccine strategies or T-cell therapies.
Yeah, I feel like bevacizumab is just such an interesting drug too, and that combination of like the being a VEGF inhibitor and blocking angiogenesis, but yet it's so important for getting the drugs to the tumors, and that balance is so unique. And so I'm really glad to see that you really do we do see the synergistic effect when you combine it with these other therapies.
Victoria, you're absolutely right. And the idea of combining a PARP inhibitor with bevacizumab is based on the idea that the bevacizumab decreases the ability of the cells to repair its DNA. And that's when PARP inhibitors are most effective.